lecture is from our curriculum, and we saw that also patients are very much interested in this lecture, so that's why I explain sometimes things more in detail, more with the simple words for patients and not only for doctors. And so this actually addresses both. This lecture is quite new. I taped this 1 month ago in our clinic in Ukraine, and I think it's very good. And at the end of the lecture, I will answer the question, okay? This is IF lecture, Implant Foundation.
The patients and dear colleagues, warm welcome to the lecture about Peri implantitis and corticobasal implants. On the example of corticobasal implants and the Peri implantitis, I would like to show you the possibilities of a new implantology, and I want to explain the differences between the new and the old implantology and a little bit about the bone, so that you understand easier or better where the differences are and where the advantages are. Now, I was given this picture and I wrote intelligent solutions below it. So as you see, there are a few men moving a cube, and it's of course very difficult to move this cube because the surface is rough and this cube is very difficult to move forward. But then there is one guy, and this guy changed the cube into a ball, and it's of course much easier to move this ball ahead. So he invested a little bit time into changing the situation and improving the situation, and from then on he was of course far ahead of the tribe, and he's of course winning the game. And this picture reminds me of our work compared to the traditional implantologists who still work with healing times and with bone augmentations and with all these things which the patients don't want. They have a very difficult life, really difficult. They're running a lot of risks. Actually, their patients are running a lot of risks. Whereas in our profession, in this corticobasal implantology, it's a kind of new implantology in a way, but it was done actually 30, 40 years ago already. It only lost a little bit market share because the attention of doctors was drawn by the marketing of big implant producing companies towards osseointegration, towards healing times, towards bone augmentation, and with all these things, a lot more money can be made on the side of the producers and treatment providers, but the results are not better, and actually they are a lot worse, as you will see very soon in this lecture. So I recommend that you open your ears and open your mind to see what I have to tell you. So I call this intelligent solution because the corticobasal implantology is basically traditional implantology. It's the same. We don't do anything different. We connect implants with the bone. But we do this in a way so that the damage is minimized. And we do this in a way so that we can load the implants immediately. This is actually what our patients are expecting. This is what they are hoping. You know, everybody today who intends to invest money into something, into building or a car or anything, wants to buy something, this person wants to have it immediately. I mean, this is simply our time. Nobody is ready to wait half a year or 1 year until he or she gets the result. Everybody wants to get results possibly immediately. I'm not talking only about war countries, you know, where nobody knows will I live tomorrow, but even in our countries, and let's say in the Western world, you know, where we had a lot of security in the past, also in these countries, we see that patients rather buy something which they can get right away, and they are not trusting so much into things which will hopefully happen in the future. It's about Peri implantitis, and I show you on this picture some examples. As you see, there were 2 implants placed, there's a crown on top, and then you see suddenly the bone was gone. This is actually the same picture. You see that this around these implants, a lot of bone was lost. You see a little bit infection also coming from this tooth. Probably this was one of the reasons why this happened. In any case, these implants produce pus, patients have pain, these implants have to be removed. And what is the worst, actually, there is not a lot of bone left. And this makes the big problem to the conventional implantologist, because they don't have enough bone then in order to restore this case again. Here, another case in the upper jaw, and as you see on this bridge, this case was solved by us in a few days, 3 days actually. We removed everything. We removed the remaining teeth. We removed all these ailing implants and placed fixed teeth within a few days. Typically, we do this in 3 days. So it's not a problem nowadays, and by our means, by the corticobasal implants, to get such a problem solved. We do this every day, and I can really tell you, if you have periimplantitis, if you're suffering from this, if you have chronic infections around implants, we have a solution. We can help you. There's a very high chance that you will have fixed teeth, even if you have lost implants or you are in the process of losing implants at the moment. My name is Stefan Ihde. I was born in Germany. I studied dentistry 1982 till 1987 in Würzburg, Germany. That's in Bavaria in the south. I did there my doctoral thesis. I worked after this in Germany as a dentist. After this, I worked from 1994 to 2010 in Switzerland. And since 2012 till today, I work in Montenegro and in Serbia. I have published 6 international textbooks in English language and in German. I have been writing 102 national and international publications in German language, in English, and in the Russian language. I'm licensed in a number of countries for work as a dentist, and I'm an oral surgeon in Russia and in Ukraine. I have worked with traditional implants from 1996 to 1997, and after this I started with corticobasal implantology, 1997 until today. I have placed more than 50,000 implants in my life, and most of them were also equipped under my supervision. Now, what is periimplantitis? Periimplantitis is a breakdown of periimplant bone starting at the first cortical, and this leads to crater-like or horizontal bone resorption and the loss of what we call the bony attachment. So the connection between the bone and the implant gets lost. The implant typically does not get mobile because there are always some areas of this implant osseointegrated. And basically what happens is that the pockets are developing, the bone is lost, this is all filled by soft tissue, and the soft tissue is then in contact with the implant, with the rough surface, and this is the problem. This actually makes the problem. This causes chronic infection, because on these rough surfaces, opportunistic bacteria can survive, and these bacteria create the infection. The body has no possibility to destroy these bacteria, to clean them out, to get this stabilized. So periimplantitis is in a way a chronic infection around the implants. Please keep in mind that we have in the oral cavity a very special situation, very unfortunate of course, because we have so many bacteria in the oral cavity. If you compare this to a hip implant or knee implant and all these implants or fracture plates, they are placed under sterile conditions. So after the surgeon closes on top of the fracture plate, there are under normal circumstances no infections. So it wouldn't matter for a fracture plate to have rough surfaces. But the companies who are producing these fracture plates know exactly that rough surfaces don't bring any advantage. So that's why all these fracture plates and hips and so on, they are polished, or they have sometimes these beads, but under the microscope you will see it's polished. And so the manufacturers of trauma implants, they know exactly that there is no advantage whatsoever in rough surface or in sandblasting or etching and so on. This brings only risks, additional risks into the therapy. That's why they don't do it. So radiologically, we can see around the implant crater-like bone loss or vertical bone loss. Usually it's the crater-like bone loss which is associated to periimplantitis. So the bone kind of recesses away from the implant, and we get like a V-shaped bone loss, and inside this V, inside this crater, we find infected soft tissue. Very often we also have a little swelling outside of the bone. So this is actually an opportunistic colonialization of rough implant surfaces, and there are the signs of bacterial infection, so rubopus, dolor, calo. This is what we all learn in the universities. This is typical infection. Looking at the scientific literature, we are getting a little confused because we are being told that there are various reasons for periimplantitis. There's a lot of actually research done on this. This research is done on periimplantitis for many years, 20 years. I mean, since these rough surfaces appeared on the market, maybe even 25 years. But science has not found any solution. And the only solution that would work, of course, everybody knows this, is to use polished implants. But this is against the marketing strategy of the big implant manufacturers, so it's probably not going to happen. I mean, not in my lifetime. So the doctors are moving on, using all these rough surfaces, and they're moving on, creating periimplantitis, and the patients are suffering. This is the situation. I mean, there are no other words for this. But because everybody is doing it, it became normal. I mean, we all know if everybody is doing it, it becomes normal. We saw this, you know, in the Dritte Reich. We saw this in the COVID times. I mean, as soon as everybody's doing it, it's very normal, and it's the same in dental implantology. Everybody's using this type of implants. Everybody has the same problem. Maybe the patients are talking to each other about their problem. Everybody has the same problem. So that's normal in our society, obviously. And so we are not being informed about the real reasons. For example, we find you see up here, patient genetics can be the reason, smoking can be the reason. So there's always a tendency in medicine kind of to move the problem away from the treatment provider and away from the product. And there's always a tendency to explain to the patient, well, it's your fault. You were not compliant. You didn't do that. It's your bad genes, your bad grandmother, whatever. Always some kind of reason on the patient's side. And unfortunately, a number of patients believe this, and I hope that my lecture today will encourage a little bit the patients, also the doctors, of course, to think about the true reason for periimplantitis, and I will give you a lot of hints, a lot of ideas what to think about. So what is the incidence of periimplantitis? So this is, of course, very difficult to answer because we all know that there are bone regions which are more stable. For example, the interforaminal region between the nerves in the lower jaw. This is a very stable bone area, and it is actually very difficult to create periimplantitis there. But there are also areas which are not so stable, where we see kind of automatic bone recession, and automatically this will be then colonialized and infected, like the distal mandible, or like the distal maxilla. The distal maxilla, we face a situation where not only from the oral cavity, the bone is recessing upwards, is atrophying, as we say, but also in the sinus we see atrophy, so that the bone, the vertical bone, becomes smaller and smaller and smaller. So then in any case, a part of the implant is not going to be covered by bone after some time, and that by itself creates periimplantitis. I will come to this later. Now, looking at the statistic, you see that Meyer et al. Found in 2014 that after 5 years, 17% of the implants show periimplantitis, and after 10 years, 30% of the implants show periimplantitis. Periimplant mucositis is a little bit more, of course. It's like in an early stage of periimplantitis. Keep in mind that this study was done exactly here in the front, in the dentures anterior mandibule, and this is kind of, you know, if you ask me, make a good study so that there's not a lot of periimplantitis, I would also do it here, you know, because it hardly happens here. So that's what they did. So these figures, 17% and 30%, don't look so bad, but if you would take the same, do the same study in the upper first molar, then probably after 5 years, you would see almost 50% periimplantitis, and after 10 years, you would hardly see any implants left in. So, you know, it always depends on how you make a study, then you get the results. They write here, it also has been reported that 40% of the implants have periimplantitis in Sweden, Italy, and Switzerland. I mean, 40%, it's a real big amount. And that there are approximately 400,000 cases of periimplantitis in the United States of America. Now, the second part of the sentence is very difficult to evaluate because you don't know how many implants have been put. I mean, this can be 400,000 out of 500,000. This would be a big number. It can be 400,000 out of 40 million, and then you would say, oh, okay, this is not a big problem. So this second part of the sentence doesn't give us a lot of information, but 40% of the implants have periimplantitis. I mean, this is really a big number. Just imagine, I mean, you're buying a car, new Mercedes E-Class, and after a year you find out 40% of these Mercedes have major problem. So, I mean, would you buy this car again? I mean, I don't want to give you the answer. I mean, nobody would buy this car again, but because the problem is hidden in the mouth, everybody, I mean, is hiding his dental problems, oral problems, and so on. They get away with this. They get away with a 40% complication rate. Oh, I mean, let's say you take aspirin, and 40% of the patients who take aspirin have a major problem. Like, I don't know, they go to hospital, something like this, have to take antibiotics or so. Nobody would take this aspirin anymore if it would be like this. Of course, it's not like this. But in dentistry, these things are nowadays deemed normal because, like I said, everybody's doing it and everybody is putting these implants and everybody makes money and there's nobody wants to stop it. This is, well, a typical example of how medicine works nowadays. Keep in mind that there is no effective treatment except the removal of the implant. So when periimplantitis starts, it goes on. It goes on forever. It might happen that the bone loss around the implant will stop one day, but the infections around these rough surfaces, which are exposed from the bone, where the bone has already disappeared, these infections remain, of course. I mean, of course, you can cut down the pockets, then you get you see a lot of these implants suddenly in the mouth, which is very, very anesthetic. I will show you a picture later on. Then at least the patient doesn't have pockets and there's not such a lot of pus. But besides this, there is not a lot that you can do. So either periimplantitis stops by itself, and actually it stops at where the basal bone starts. I mean, there we have this alveolar bone, crestal bone, and the basal bone. And the basal bone is very, very stable. And the periimplantitis cannot so easy progress into the basal bone, so then it can stop. Or there's a palliative approach, and these implant surfaces are polished. Now here's such a case, 2 implants which I took out recently in one of the clinics where I work. So some doctors, so these implant surfaces, no, this is a screw implant. So this was a screw implant surface up to here. It was all sandblasted, acid etched, you know, the latest technology. But of course, periimplantitis happened. This is after 5 years. And as you can see, the doctor was then desperately trying again and again to polish the surface to stop the periimplantitis. Well, no, it's of course a nice approach. Of course, it's good to polish that because if it's polished, not so many bacteria are going to sit on the surface. But on the other hand, down here, on this interface between the implant and the bone, on this borderline, you cannot polish into the border. So, I mean, this is a nice idea to do this. Also, I mean, it's right to do this. But we have to tell the patient this will not really help. This will not solve the problem. It will only, let's say, prolong the life of the implants or prolong the suffering, whatever it prolongs. You know, it's like this. Nothing stops periimplantitis, and the reason are, of course, these rough surfaces when they are exposed. And you know, when I took out this implant, I actually called the doctor who put this implant. I said, yes, you know, I did a big job. You know, it was polished several times, again and again. I was polished. And then I asked him, okay, but let's say next week, you're gonna put a polished implant then right away, or you're not gonna do it? And simply this was the end of the telephone call. You know, there was no answer to this. You know, this is how how these doctors are believers. They believe in doing it, and so they believe it has to be rough, and later they see the problems, then they polish it. They understand polish is much better, but then they go back into the clinic and put the rough implant again. So if you do the same thing again and again, so how can you expect to see a different outcome? I think no possibility. It will be always like this, and I don't know how to change this. So it's actually the informed patient. So this is why I give this lecture to you as a patient. Only the informed patient can run away from this craziness and look for an implant which has no perimplantitis, look for an implant which works in immediate loading, looks for an implant which doesn't have all these risks and complications, an implant which doesn't require bone augmentation, and so on. And these implants are available, and there are doctors available who know how to use these implants. So I'm giving you this lecture to make you aware of this. Also, this lecture is to doctors to make them aware, to dentists to make them aware that there are other possibilities. There are other things well explored in this world which are working and which don't bear this risk. This slide is about differential diagnosis. So you see two implants here. One implant has this crater-like bone loss that you see here. See, this is all soft tissue here. And this soft tissue is in contact with the rough surface of the implant. And the implant is, of course, at this stage already colonialized by bacteria. These bacteria are producing, let's say, their excrements, and this creates then pus. Also, bacteria are dying. Soft tissue cells are dying. So this is what we call a very heavy infection around these implants. And to understand the difference, this implant is in like a little dark black ball, and this is what we call ostitis. It's an infection inside the bone. Here the bone is gone, perimplantitis, and here the bone is not yet gone. There's only a heavy infection. The mineralization goes down, and probably maybe this is a piece of amalgam which was left inside the bone, or a piece of whatever. And this can, of course, maintain such an infection for forever, for many years. As soon as the implant is put, then this kind of blows up and you get a real big infection, and quite true also this implant gets lost and after some time. As you see here is a periapical ostitis. Also here around this root canal treated tooth, you see overpressed root canal filling material, and you see an infection. Also here the bone has a lower mineralization. In the case of perimplantitis, the mineralization around here towards the apex of the implant is quite high. So there is no infection, but there's only crater-like bone loss. This picture was given to me recently. The crowns are one piece, so it's a block of crown on those two implants. This is, of course, always a very unfortunate situation, because blocking these implants takes away a lot of the elasticity of the bone, because the implants actually are stiffening the bone too much. And we know nowadays that this type of blocked crowns create much more perimplantitis than if you keep single crowns. I mean, it could be also two single crowns on those implants. You see that the bony attachment seems to get lost here on that side. Probably this is why there is not so much perimplantitis. But you see in general that the bone line goes down here, and it also starts to go down here. So this is for sure crater-like bone loss on the left implant. And I would say that the right implant, I mean the right on the picture, is probably mobile, but you don't notice it because these two crowns are blocked to each other. Similar situation here, a lot of bone loss around this medial implant. These are also blocked together. I mean, they're not single crowns, but they are blocked. And this, of course, over stiffening the bone. You could say this is like the stress shielding effect in the fracture plates. And this always leads to a loss of bone. I will show you later on an example for the stress shielding effect in a hip implant. You see exactly what you see here, you will see on the hip implant also. There are some doctors who like to connect implants to natural teeth. We don't do this. I mean, we do this in very, very, very rare cases if we have no other possibility. Because, of course, these implants are osseointegrated, so they are stiffly connected to the bone, and this implant has inborn elasticity from the desmodontium. So this is, anyway, I would say, not a very fortunate case. Here you see bone loss down to here. There's only maybe 1/3 of the implant is still in the bone. The periimplantitis starts also here. So as you see, these implants are basically lost. Implant is on the way to being lost. This implant looks quite okay. So 5 implants were placed. 4 implants out of 5 have periimplantitis around them. I would say this is a pretty normal situation, especially because there are still teeth in the mouth. Also, I don't know why the doctor connected the teeth to the implants, but he did it or she did it. And this is a situation like we see it almost every day in our clinics. Also on this slide, you see generalized bone loss on the left side, bone loss on the right side. Also, there's a bone augmentation already let's say, not so sure if it will catch because you see gaps here. So bone augmentations are then done by those conventional pathologists if they want to restore the case. The strategic implantologist or the corticobasal implantologist would, of course, remove those 2 implants immediately, would take out this bone augmentation material, remove all the teeth, of course, there's no other option, and put 8 implants. I mean, 2 implants here, 2 implants in this front corner, 2 implants there, 2 implants there. And these implants would then be enough for an immediate loading construction. And this case could be solved within 3 days. I'm just explaining you this to understand that this conventional implantology with a bone augmentation, with these healing times and so on, this is something which basically we don't do anymore. I mean, I'm not doing this for 20 years. Many other doctors who now switch from traditional implantology to this, let's say, new way of implantology, corticobasal implantology, don't do this. I mean, there's millions of implants being placed. So this is not just a weird idea or something which has worked 1 time or 2 times and never will work again. This is a scientifically proven method. What I'm teaching you or what I'm making you aware of, and to solve such a case would take us exactly 3 days. And we are not waiting for the bone to heal or the osseointegration to take place. We are actually waiting for the dentist technician to give us the bridge. And unfortunately, 3 days is typically the time that they need, and 3 days is also the time until the osteonal remodeling starts. And the osteonal remodeling kind of creates instability around the implants inside the bone. And as soon as the remodeling starts, we should be ready with our work, because then the bridge is needed as a device to splint the implants. So we are selling, of course, to the patient's immediate loading, but what we are doing actually is immediate splinting. Immediate means within 3 days. Now, also on this slide, this panoramic picture, you see severe bone loss almost around this distal implant. So there's the bone kind of getting lost all around. Here you see vertical bone loss. A lot of teeth are decayed. So this is, of course, a case out of control. Patient probably didn't come. Patient didn't do the necessary repairs on the teeth. And then, of course, the infection became bigger and bigger and took over. But as you see, the most interesting thing in this picture is not the lower jaw. The most interesting thing, in my view, is the upper jaw, because although, I mean, the lower jaw is already disaster with those 3 implants, with the periimplantitis. This was a really profound periimplantitis, chronic infection already for a year. Here, big crater-like bone loss down to the socks. And what is this colleague going to do? You see the plan here, upper jaw, he's going to do the same thing again. Now, I don't want to tell you. I mean, obviously some people never learn. I mean, they see it doesn't work or it makes problem and they do it again and again. So I don't know what to tell you. I think it's wrong. Doctors should reconsider. And in the end, it's the patient who decides. If the patient goes to a doctor who does it, he's going to have the problems. Okay, so what can we do? What can I do? I think patients should be more informed about the new possibilities, and this is what my lecture is about. This picture was taken out of a magazine in Switzerland, dental magazine. The interesting thing is that 85% of the bone gets lost quickly, and then this apex of the implant, this upper part of this implant, is in the bone. That's very stable. The periimplantitis is not going to continue at all, and now there's two things to learn from that. First of all, in our textbooks, when we learn about peri-implantitis, why this happens, we are kind of told that because this implant is subjected to lateral force, from this chewing, then here on this collar, the forces are too high, and from this the bone disappears. Now, this is, as you see, this is of course completely wrong idea, stupid idea, because I mean, just imagine how much higher are the forces now. I mean, now you have the collar here, you have enormous cantilever, and you don't see bone loss anymore. I mean, from here to here, from here to here, this happens maybe in 3-4 years. But from here to here, so that the rest of the implant is also without bone, this probably happens never. Now, this situation is stable. So this idea that these collar forces, this FEM analysis showing this big explorations of the universities, they show that this is all true, but it's of course not true, because the examples of these cases show us that the less bone there is left around an implant, the more durable this is, the more stable is the situation. Now, why is this so? Because now the implant is osseointegrated or anchored in what we call the basal bone. And the basal bone is a very, very stable bone, and all these tendencies to infect this bone are not strong enough to make this bone disappear. I mentioned already several times the word corticobasal. So corticobasal consists out of cortico, from cortical, or this hard bone, round bone, and basal. So corticobasal implants actually are utilizing this type of bone, which is left here only. And that's why they are so successful. And all the rest of the bone, which is here already lost, is not used anyway. This implant never needed this bone, which is now lost. But of course, this implant was leading to destruction of the bone because of the rough surfaces in combination with the bacteria. So that's why the bone is gone. But this basal bone is, of course, still there. Or look at this case. See the bone loss up here. No, the patient has pockets more than 1 centimeter in the lower jaw also. I mean, this is not a very old implant case. It's a few years old. As far as I remember, maybe 6 years old. But as you see here, a lot of bone was lost. And as you see here in the front, that's what I mentioned before, in the front, and especially because there are teeth next to it, we don't see bone loss and we don't see peri-implantitis. So peri-implantitis is also, of course, creates itself in areas where we have total edentulous, so there are no teeth that are holding the level of the bone. Then the level of the bone goes down, and then we see peri-implantitis. The same here, you see the implants are without bone until the area where the basal bone starts. You see a little bit more white on the picture here. You see higher mineralization. So this is the border to the basal bone, and these implants can stay like this more or less forever in this situation, as long as the basal bone line remains actually in this height. This is a special case, all on 4. I'm not sure if you had this. We take out a lot of these all on 4 cases. This case was very special. That's why I show you this, because the doctor has made not 1 bar, but the bar was made out of 4 pieces. And of course, then there's a lot of instability already in the bar. So this is not going to splint the implant, and that's why this failed. Now, this picture is also interesting for those of you, especially the dentists listening here, or implantologists, because we are being told by the university or by the textbooks that the surface of an implant should be made as big as possible, as large as possible. And in order to get the surface of a solid body large, they can sandblast it, they can acid etch it, and so on. So then this acid kind of digs deep into the surface of this implant and etches out. And then, of course, we get this type of undercuts, and the surface is then larger than before. But what this picture tells us is that these large surfaces, they are not necessary at all, because, I mean, look at this implant. This is almost not connected to the bone. So, I mean, the bone in the old times was up here, there. And this implant is not connected to the bone at all. This is not connected to the bone at all. Only this implant is connected to the bone in the apex area. So in this lower part of this implant, so let's say 1/10 or 1/15 of the surface of the implant is now osseointegrated. These implants are not osseointegrated at all. And what is the most interesting story? It's not mobile. This is not mobile. It's stable. The patient is chewing on it every day. Although all this bone is lost, the big surface is not required in order to create a load transmission. So this implant is integrated, a little bit apex is also integrated, and it does the job for this implant and for the two other ones also. So I have to ask the question, so why are we then sandblasting, acid etching implants if this works? I mean, we see this every day. It's basically the same story here. We see this every day. Here, for sure, 70% of the surface, the endosteal surface of the implant is not in contact with the bone anymore because the bone disappeared, and it works. Here, I would say 90% of the bone is gone, and it works. I mean, the implant is stable. There's lots of infection. The patient doesn't like it. I mean, there's chronic infection. Push day and night. This is not a question. But the implant works. So why does it work? It works because it's integrated in the basal bone. So this is what we call basal osseointegration or cortico-basal implants. This is how they work. The only problem with these Straumann implants is they have the wrong surface. That's why there is an infection. See, there's basically nothing wrong with these implants. Only the stupid rough surface makes the problem. This is what causes the patient pain and tears for years. And this is not the only patient. We have hundreds of thousands of patients with this problem, and it's only because the wrong implants were put. So now, what are the assumed reasons for periimplantitis? There was a survey was published in SSO Zeitung in the Swiss Dentist Journal. They were questioning Swiss dentists about the assumed reason, what they think, why they have periimplantitis around the implant. Now, I mean, this is not a joke. This is a true copy out of the Swiss Dentist Journal. Now, 79% said this is from periodontitis. Can you imagine? So, I mean, of course, there are a lot of patients who don't have teeth anymore, so where do they get it from then? But, 70% says it's from periimplantitis. Then 76% says it's from the smoking, from the bad compliance. You see, those smoking and bad compliance, this is the tendencies of the doctors to move this problem to the patient. It's your problem. You didn't come, you smoked, you drink too much alcohol, you kissed the wrong girl. Whatever you did, you should comply. Please comply. If you don't comply, it cannot work. But how to say this, even if it would be like this, all our patients are normal human beings. I mean, nobody is a god. No, they are not going to stop smoking. They are not going to drink alcohol. They're not going to stop kissing the girlfriend. They are going to be normal people also in the future. So how can you give a medical device to a person which doesn't work for the normal person? How can you do this? I think it's simply wrong. So the doctors should give medical devices, they should give implants to the patients who are not affected by the smoking, they're not affected by anything which the patient cannot leave, they will just do it. The smoker smokes, the drinker drinks, nothing will change. So this bad compliance, I mean, what can we expect from compliance? We can expect that the patient turns up for the control, for the occlusal controls, mastication control, maybe for the cleaning control. But after this is the end of the necessary compliance. We cannot expect more from the patient. We cannot expect to change the habits, the addictions, the religion, whatever. The patient is the patient. We are being paid for doing things which help this patient. So obviously this two-stage implantology, this conventional implantology, is not something that helps to the majority of the patients because they are simply normal people. Now, parafunction, this is something which I have to accept. I mean, if the patient is bruxing too much, then there can be problems with the implants. Then you see 24% of the dentists were thinking that the smooth implant surface made periimplantitis. 31% were thinking that the rough implant surface made periimplantitis. I have to say, Swiss dentists, they even start to believe that the rough surface make periimplantitis. So, and even a smaller number thinks that the smooth implants make periimplantitis. Then short implants, reduced diameters after sinus lift, after augmentation, after immediate loading. 30% think the immediate loading makes periimplantitis. Now, I don't know what to tell you, but I think simply the Swiss dentists don't have too much of a clue about all this, but this is the situation. I mean, this is the leading nation in dental implantology. So what are the true reasons for periimplantitis? Now let's look at the facts. Now there's a bone loss for structural reasons, especially if there's not enough elasticity in the bone. And this is the case if the implant is stiff. Bone can also integrate a stiff implant, like a two-stage implant, big diameter, rough surface, and so on. This all works, but after the osseointegration is finished, I mean, this osseointegration starting with a woven bone formation, and then leading to osteoid remodeling, the real, even sometimes cortical osseointegration. But after these first repair processes are finished, woven bone formation does not depend on function. It depends on the injury in the bone and the blood. But after this, there is function necessary to maintain the bone. And obviously, this is not so well known among the implantologists. So if the implants are big diameter, if they have this tube type design, if they are stiff, actually too stiff, then the bone will disappear later on, because the Wolff's law, you remember maybe Wolff's law from 1892, says clearly that the bone mass is always optimized according to the amount of function. Now, if the implant is stiff and takes the function out or away, shielding away actually, it's a stress shielding effect, then the bone mass is going to be down. So this is one of the main reasons why we see periimplantitis. And so how to avoid this type of periimplantitis? Just choose different implants with a different elasticity. Then you will see periimplantitis will not happen. Connected to this, I write here too much bone mass, not enough function. It's of course the same. If there's a lot of bone, I mean, not an atrophy case, really a lot of bone, then typically the patient doesn't have enough function to maintain such a lot of bone. The same is actually true in the case of periodontitis. So why do we see bone loss? At the age of, let's say, 35 to 45, beginning at this age, we see this because there is not enough function anymore to maintain the bone. The bone kind of gets older and older, so it gets a little bit sclerotic. That is not so elastic anymore, and then we see the periodontal breakdown. And there are some bone areas which resorb stronger. For example, in the maxillary sinus, we see expansion of the sinus. And here in the first cortical, especially in the distal upper jaw and distal lower jaw, we see also atrophy. So this leads to a stronger resorption. And no, the question is, why do we put implant then there into this area if we know that there's a strong resorption? And the answer is, I don't know. No, why are we doing this? I mean, there's enough bone everywhere around which never resorbs. No? So why not to use these areas? And why to make a sinus lift here to lift the bone, make a bone augment, put some whatever stuff in from cows and pigs in order to create bone where bone simply doesn't want to be. In my view, it's not a nice idea, but of course a lot of dentists are doing this. The other point that I want to remind you of is that large implant's diameter, the larger the implant is, this interrupts the macroterritorial load transmission. So what do I mean by this? The bone, through this bone are traveling osteons. These osteons are the structural units of bone. And if there's an implant, let's say, and this osteon comes along and wants to travel, then the osteon is stopping, and maybe it goes around the implant and continues there. Maybe it just stops. But in any case, the run of the osteons is interrupted by this. And around the implants is happening disuse atrophy, and the osteons cannot form like they wanted to or like they have to, and this of course leads to bone loss. Now this is the example that I was talking about before. This is a hip implant, a crosscut, after 16 years, the implant was in here. It was a cemented implant. This is the cement. The implant was metallic. It's out from the picture. We don't see it here. But what you see is that on the non-operated side, we have a normal structure of the bone. I mean, normal morphology, normal thickness of the cortical. These black lines are only from the holders to hold the bone. But on the operated side, you see much less bone mass. I think everybody sees this. I don't have to give you examples and percentages. And you see a completely different structure of the bone. You have a cortical here on the inside suddenly. Then you have very osteoporotic bone around this cortical with a few struts connecting the inner cortical to the outer cortical. And here's a little bit more bone. So why I'm showing you this? I'm showing you this to explain that whenever you put a stiff implant, the stress shielding effect is going to happen, and you're going to see atrophy. You're going to see a loss of bone. And this is not only true for the hip implant, this is also true for dental implants, for stiff dental implants, especially this tube type. Now there are, of course, other factors like iatrogenic factors which are created by the dentist or by the design of the implant. So cement rest can lead to peri-implantitis, of course. Bacterial leakage can lead to chronic infection, to leakage of toxins, and of course overheating of the bone can also prevent osseointegration. So now, what are the implant-derived reasons for development of peri-implantitis? First of all, of course, the exposed rough endosseous implant surface. So as soon as the rough surfaces are in contact with the oral cavity, so they are not in the bone anymore, but they are, they're in contact with the soft tissue, then bacteria, natural bacteria out of the oral cavity are going to colonialize these surfaces, and as soon as the bacteria are there, they feel very well. They are not going to go away at all. Then the T cells, B cells, macrophage, and so on, they all try to kill this bacteria, but on the surfaces, they are very well protected. Nothing can kill them, so it's going to be a long fight, and nothing is going to happen except that more and more and more bone is lost. The next point are large implant diameters, because of course, the larger the implant diameter is, the more bacteria are going to be present per implant. It's very simple to understand. And of course, the multi-part design of the implants is leading to this unnecessarily large implant diameter. So if you have a single piece implant, like one piece, one shaft, 2 mm diameter, then it is not necessary to have an internal screw connection or any other connection to make those two parts fit together. The diameter of the implant, the core diameter is going to be 2 mm, for example. Titanium, aluminum, vanadium as a material, 2 mm as a diameter. But as soon as you need this internal drilling, you are easily 4 mm, 4.5 mm. So the implants are much bigger, and then in many cases the implants are much bigger than the bone which we have available in the upper and in the lower jaw. So those 3 points, the rough surfaces, the large implant diameter, and this multi-part design, so multi-piece design, implant plus abutment, and so on, these are the reasons for peri-implantitis. So in other words, the choice of the wrong implants are the main reasons why we see peri-implantitis. So if every doctor would use polished implants with a thin shaft diameter, small shaft diameter, and single piece design implants, peri-implantitis would not appear. This has been shown in a number of scientific investigations, so this is all known to the public. This has been published in high-ranking PubMed journals. Nevertheless, our profession doesn't want to accept it, so they continue like they did before. I also want to point out that the cost of maintaining the implants are higher than the cost of installing the implants and putting prosthetics. This is a statistics which has been shown by a private German health insurance. So for example, if the installation of the implants plus the bridge are 20,000 euros, the maintenance of this over 10 years costs another 20,000 euros or more. This is, of course, an amazing sum. It means because we some doctors are putting these implants, they're going to make a lot of money over the years by maintaining them, by repairing periimplantitis, by taking them out again, putting bone augmentation, putting them in again, and so on. So this is an ongoing process, and I would say nobody, not a sensible person would not buy a car which has so many problems like the implants, which are being put in by somebody who takes decisions which implants you are going to get. And so I can only advise the general public, the patients, you as patients, to get informed about the situations and to influence the choice of the implants, because it's going to be your implants. You're going to run around with them and you're going to have problems like periimplantitis, or you're not going to have periimplantitis. And of course, nobody wants to have periimplantitis, and it is not necessary nowadays to have periimplantitis. This is an old problem. Now, talking about periimplantitis, as I explained before, this is an infection of the soft tissue around conventional dental implants with big diameter and rough surface. If it would be only for this periimplantitis, I mean, let's accept it. Okay, why not? It's very bad. A lot of implants are going to be lost, so we put them new, we make bone augmentation, and so on, and so on, and so on. But there's another point that I want to mention here. I write here, periimplantitis might trigger oral squamous cell carcinoma. And this is, of course, a different story. Suddenly, we are talking about carcinoma, about malignant processes, which are being triggered because periimplantitis is there. I mean, this is another category. I mean, this is definitely something which the normal patient with a fully informed consent would not accept. I think so. Nobody would accept this if the patient would be really told this is the situation. You can get cancer from this. Cancer cells are developing regularly inside periimplantitis. There is an article writing about this is a dilemma. You know, dilemma. Was it a periimplantitis or is it a cancer? Wow, what a dilemma. Of course, nobody wants cancer cells. So if you have implants which can cause periimplantitis, or if you have periimplantitis already for many years with deep pockets, the chances are not so small that you are one of these patients who are going to suffer from this cancer, and these cells simply, they are there. Also, there are a lot of articles showing that other cancers, like breast cancers, other cancers can deliver metastasis into the periimplantitis, and suddenly you have a metastatic tumor, malignant tumor from the breast you have suddenly in the mouth. So I would say nobody wants to have it, and I mean, if this can be avoided, then I think everybody will avoid it. So this is another point why we don't use rough implant surfaces at all. So this is not a single publication, but there are hundreds of publications showing this. Only nobody talks about it. This is kind of, this is a scientific stuff. Oh, it happened one time, it will not happen again. But there are publications talking about 100, 150 cases. So this is not a rare risk, I would say. You see this all, oral squamous cell carcinoma, you see this all here. So it happens. And it's plasmacytoma, the epidermoid carcinoma. And so this is something which is a real risk to every patient. That's why I recommend not to use these big diameter, rough surface implants, regardless of what kind of great brand this was manufactured. Simply, I mean, it happens because this is an implant with a rough surface inside the bone. There's an infection, chronic infection. This is it. I mean, you cannot say that any big brand, I mean, you know, they cannot say our implants don't have this. It is simply every rough implant has this risk. Now, I made a few simple drawings to explain the situation. So this is a typical schematic two-stage implant anchored in the first cortical. Up here is the first cortical, stiff design. No? This is a corticobasal implant anchored in the second cortical, elastic design. So this here in the first cortex is a non-stable situation. The bone will recess a little bit. It always recesses. This is only a question of the osteoidal remodeling. And then the surfaces are exposed, the surfaces, and you get periimplantitis. This is simply going to happen. Here on this corticobasal implant side, we have a stable situation. Even if this recesses, both implants can, both sides can show recession of bone. There will be no infection because the implant surface is polished and because the diameter is thin. This is the big difference. It is not a two-piece design. And here you will see no infection, and here you see infection, and you see more and more infection, the more the bone disappears. So these implants, I write this here, the aim to design implants like roots of teeth is unbelievably stupid, and it has a lot of disadvantages. So these implants were designed, they like to copy the roots of the teeth. And of course, if you copy something, you're going to have the same problems in the end, and these implants have the same problems. This is the reality. Now here's a case which really demonstrates what can be the result. You see all this bone was lost, all this implant surface exposed. Luckily, there are no deep pockets, so this is now easily cleanable. But it's of course not aesthetic, it's stable, but it's not aesthetic. A lot of bone has been lost, so why does this patient not allow to take the implants to be taken out? Because he knows exactly, if this is out, nothing will be and nothing ever will hold. And for these patients with a lot of bone loss, with the corticobasal implants, we have very, very good solutions. I mean, we can fix this problem in a few days. Another example here, I took this out of a textbook. Of course, these implants are too close to each other. The implant diameter is too big. I mean, this bone simply cannot be nourished between those two implants. And as you see, as soon as these implants are placed a little bit divergent, so as soon as there's more space between the implants, periimplantitis stops. Of course, there's also basal bone, that's why it stops. And this is, of course, a dentist mistake, but nevertheless, it's periimplantitis, the patient is suffering. Now here's the typical case as we see it every day. Upper jaw was treated here, and the lower jaw is full of infection. You see periimplantitis here, ostitis, periapical granulation, infection, periimplantitis, and so on and so on. Infection from root canal meets infection from periodontitis. So all this goes out, and in the same moment, we put the implants in, here, there, and there, 8 implants in the strategic positions, and equip these 8 implants with a splinting bridge, and the patient is back to function after 3 days. And then you see a few months later, 3 months after lower jaw treatment, you see how this bone remineralizes here. You see this big defect here, already mineralizing from the periphery. Here, this crater-like bone loss going away. Very nice and fresh bone, good bone here close to the implant. You see a lot of black here. See this implant? You see nothing black here. It's already healed. And within a few months, this is completely healed. Within 1 year, the bone line is going to be just straight. It's going to be a straight line, no crater-like bone loss. And this is what we have to offer for the patient. I think this is a genius development. This really solves the problem of periimplantitis. It also solves the problem of periodontitis, so we can treat patients even with heavy infections. We can treat basically all the patients with the exception of, for example, IV bisphosphonates. There's a few patients, few groups of patients which we don't want to treat. You see that the whole mandible is starting to consolidate. Upper jaw also looks very good. This is what we have to offer with the corticobasal implants. This is how we are going to solve the problem of periimplantitis. So solving means taking out two-stage implants. I mean, we cannot improve it. No, we cannot talk it good. Simply, this implant needs to go out. Infection will stop automatically and instantly, and we can put new implants in, polished implants, thin mucosal penetration diameter, and everything is good. I'm not saying that there's never any problem with the corticobasal implants. There are sometimes problems, but at least we don't see periimplantitis. So we don't have this looming problem, which sooner or later hit almost every patient with two-stage implants. Here another case, you see two-stage implant, periimplantitis, two-stage implant, periimplantitis, periimplantitis. This already was cut out, periimplantitis, periimplantitis. You see infection wherever you look. There was a bar on top, and on this bar was some occlusive denture. This is anyway something that I don't recommend, because it's these removable dentures, they kind of develop their own atmosphere. I mean, if patient doesn't take that out for 2-3 days, so this can be very occlusive, and this infection is going to go down along the implants. So I don't like to do it. We sometimes, in very rare cases, we have to do it for also for medical reason, or because patient is a bruxer, or because he's a really heavy bruxer and there's very little bone. So this combination needs, needs us to make some compromises, but in general, we make fixed teeth because this is the safest for the patient. So here you see all these heavy infections. We took out all the implants, we took out this molar, put a tripod here, put 2 implants there, and we're using this molar. So 1, 2, 3, 4. So this is, again, the strategic positioning of implants. We were planning this for 6 months approximately. We told the patient to come back after 6 months. When I prepared this lecture, it was maybe 1 year ago. Already the patient was not coming for 6 years. He only sent us every now and then panoramic pictures, so everything is okay. So patient seems happy with the situation. And in my view, he's still under-equipped. I mean, there should be a few more implants, but as you can see, these things can go forever.
Why the BOI implant is not used usually nowadays, which is smooth surface, preferred to the BCS or the KOS implants?
Mm-hmm. Well, I wouldn't say it's not used anymore, but I don't include it into my regular teaching anymore. You see, we were using the BOI from approximately 1996-7 until 2006-7-8 a lot, as this technology of the corticobasal implants was not available. Also, the methods were not available. So region per region, we were replacing the BOI by the BCS implants because we found out how to engage into the second cortical. And first of all, the idea of the second cortical and third cortical had to be developed. We did this, and then we kind of tried to find more uses for the BCS implants because they are much more simple to insert. It's much more easier surgery. But there are some indications, I would say, where, for example, triple BOI is an excellent implant. So I'm using it. I know a lot of other doctors are using it. When we see this from the orders, they are using it. Some patients don't have tuberopterygoid region, so we cannot really engage there in this highly mineralized bone. So a single disc BOI of 12 millimeters is always a good answer for stability in the distal maxilla, or 9/16 in the distal mandible. If there's something wrong with the second cortical, especially if there was some resection or any other problem, and then this is a very good implant. I wouldn't say it's not used anymore. I'd say that it's much less used because it's very difficult to teach, I would say. This was the big thing. I remember giving courses 20 years ago, 25 years ago in Germany, when the doctors saw the surgery for 2 jaws and BOI. I mean, it was too much for them. So very few really made it. And of course, this limits the possibility of selling those implants and possibility of helping the patient. So that's why I was quite happy when the species, was developed and more diameters were available, more length and so on. We understood that sometimes even 29, 32 millimeter is necessary and so on. See, we had to learn all this. We had to dare all this also to do it. It didn't come from nothing. And so I think today is much easier.
Thank you so much, Doctor. We move to the next question. Are the basal implants totally surgical driven than prosthetic driven?
This question doesn't really apply. You see, I mean, we are placing the implants so that we are utilizing the highly mineralized bone. This is the number one point. Second, we are placing the abutments of the implants into a position where they can be used easily for prosthetics. So it's actually both. I mean, if you put an implant without thinking about prosthetics, you will never come to a good result. We are very lucky that we can bend these vertical shafts of the implants today. This titanium aluminum vanadium is an alloy which allows bending easily, and we have a 2 millimeter diameter of the implant only, so it's much easier to work with these implants compared to two-stage implants. You know, I mean, two-stage implants, from my point of view, and I'm 58 now, is very complicated. I don't want to do that. I don't want to make the flap and then, you know, to submerge, and I don't want to do it. You see, the second easiest, this is KOS. You know, I mean, still you have a rough surface, you have to put it into the bone, but the most simple implant, really for stupids, that's the easiest. I mean, you learn the methods and that's it. You don't have to study a lot. You know?
Thank you very much, sir. We move to the next question. What is the prognosis of strategic implantology in full mouth cases?
I think that's the best indication, because we have all the freedoms that we need. We can determine the vertical. We can determine the position of the arches in sagittal direction. We can determine how much teeth are going to be shown by the patient when the patient smiles. We can cut off the bone, you know, bring this bone level up so that this transition zone between the bridge and the patient's gums is in a non-visible zone. So this is the best. And if you ask me, you know, for my birthday, have the wish free, do 10 segments or 2 full jaws, I will take the 10 full jaws. You know, this is really, it's very easy. It's easy. You know, it's easy. I mean, I'm not saying you don't have to learn nothing, but when you used to do this, we do up to 14 jaws per day in our clinic. I mean, simply this comes easy. I mean, with which technology can you put 150 implants a day and go home and drink a beer, you know, and enjoy life? I don't think you can do this with anything else.